Hello, welcome and kumusta? Thank you for joining me. This is How, your occupational therapist, and welcome to OT Conversations. In this episode, I'd like us to have a discussion about a topic that is not normally discussed by occupational therapists, as it is commonly discussed by our colleagues, the physiotherapists. But I'd like us to have a talk about it because it's an interesting topic and we need to know. Because at the end of the day, this, I feel, is still a very basic information and an essential information for us to know. And what is this topic? Drum roll. It is gait. That's right, guys. In this episode, I'd like us to have a conversation about gait. We want you, and I want you to understand about the gait, and we'll talk about the basics of walking. Walking may not be our particular topic of interest, but it is functional mobility. And if it is, then it is an area that is a domain of occupational therapists, particularly in the knowledge base. So, what do we know about gait? It refers to the way a person is walking, and it involves a sequence of movement that allows smooth and efficient movement or locomotion. And a proper gait will require a good coordination of the muscles. It requires good coordination of the joints and then the nerves. And we're only talking about muscles here, right? We're not even talking about the equilibrium reaction. So that's reserved for another date. But we're just talking about the gait, okay? There are phases. There are two phases. There are two major phases of gait. And both of these phases will have subphases. Okay, so that's first thing to remember. When you're talking about phase, two major phases. The first one is the stance phase, which is about 60% of the gait pattern. And when we're talking about stance phase, this is when the foot is in contact with the ground. That's the first phase. 60% of the gait is all about standing or where the foot is in the ground. Then the next phase is the swing phase. And this is about 40% of the gait. And this is when the foot is off the ground and it is moving forward. All right. Like I said, there are some sub phases, and we'll talk about that. Let's talk about the stance phase now, which is, like I said, 60% of the gait is stance phase, and this is when the foot is on the ground. What happens here during the stance phase is that the foot supports the body weight, and it is also preparing the person to take the next step. So what are the sub phases? What are the sub phase for this stance phase? Just remember, say you're thinking about the right leg, yeah? It starts with the heel strike. Just imagine taking that first step here. We're talking about the right leg. There's going to be a heel strike. And then after that, the right leg will assume a foot flat, which is the loading response. And then the next one would be a mid stance level. And then there will be a heel off, and then there will be a toe off, which would have been a pre-swing. So let's describe what's happening. During the heel strike, the heel makes the first contact with the ground. That's easy. After that, then there is going to be a foot flat. So the foot will just assume a flat position and it transitions. The foot is transitioning from the heel to having a full contact with the ground. That is a foot flat. Mid stance comes afterwards. And this is when the body moves over the planted foot and you are shifting weight onto it. mid stance. The next one would be a heel off. And here the heel lifts as the weight shifts to the toes. And then after that will be the toe off, where the toe pushes off, propelling the foot forward. Okay, that's the first phase, 60%. And that is, we're talking about the right leg. So now we're on the toe push off, or on the toe off, which is pre swing. Now, once the foot is up, you have now lifted the foot, the right foot, off the ground. Now, the left foot is now standing. And so you can now have the swing phase. So the swing phase, there are three parts. The initial swing, where the foot leaves the ground and the knee bends to clear the floor. That's the initial swing. Then you will have the mid swing, and this is where the foot swings forward and the leg is aligning with the stance leg. So that's mid swing. So really, the stance phase of the left leg, the mid stance, would be the mid swing, yeah, on the right leg. And then you can have the terminal swing, where the foot is then preparing for the heel to strike, and which is ready for the land. And then it repeats over and over again. Very easy, guys, yeah? Stance phase, swing phase. Okay, just do the walking and observe your foot as it's doing its regular thing, and then you'll remember it. Now, there will be some normal gait patterns and abnormal gait patterns. And when we're talking about a normal gait pattern, there should be a symmetrical, it should be balanced, it should be energy efficient. So it shouldn't tire the person out so much. So if there are any musculoskeletal, or if there's any neurological impairment that will affect the leg, it will cause an abnormal gait pattern. Okay. So when you're walking, it has to be normal, it has to be efficient. Shouldn't have to worry about those things. So anything that can cause some abnormal gait patterns would be neurological problems. You can have musculoskeletal disorders as well. All right. Now let's talk about some of the gait type. And I like doing this because I like to demonstrate this. If you can, and if you remember what I'm talking about, try and imagine it and try walking that way. Because when you do your gait patterns and your gait type, then you will remember what type of gait pattern is that. Okay, so the first type of gait is antalgic gait. And by description, this is a limping gait. Why would a person be limping? Usually because of a pain avoidance. So in here, there is less of a stance phase, okay, because the person does not want to put a lot of weight on that leg. So a possible cause can be arthritis, you can have fractures, you can have sprain, anything that can cause a painful leg. Antalgic gait. What you would remember here is the word algia, antalgic, algia. So that's painful. Another type of gait is an ataxic gait. An ataxic gait, by description, it is an unsteady gait that is wide-based steps. So you can see a person having a wide-based staggering gait. Watch out for these. These is called an ataxic gait, usually observed from people who has cerebellar dysfunction, who had a stroke. That's antalgic gait, right? Or those who are intoxicated, because coordination is impaired. The person needed to balance the body so they'd have a wider base of support. Ataxic gait. The next type of gait is a Parkinsonian gait, or a festinating gait. This is a shuffling. It's described as having small steps with reduced swing of the arms. Very typical for those who has Parkinson's disease, Parkinsonian or festinating gait. The next one would be a gait called Trendelenburg gait. And in here, the hip drops on the opposite side during the stance phase. So if the hip of the right leg is on stance phase, the hip will go towards the left side. A hip that drops on the opposite side during the stance phase. Why is this happening? Because the gluteus medius is weak and you have a very weak hip abductor. Gait. Particularly, you would observe this for people who's had hip operations where they cut through the gluteus medius, because gluteus medius would be a hip abductor rather, and that's what happens. Okay. The next type of gait is a steppage gait. And in a steppage gait, you would have an exaggerated knee and hip lift. And the reason why a person would do this is because they wanted to clear the foot. They don't want to stumble. This is common for people who has problems with foot drop. Where would you find foot drop? People who has neuropathy. Stroke is another one. Diabetic neuropathy, for example. Yeah, steppage gait, because you're having a steppage gait. You can almost hear a foot slap as it lands on the ground, because it's usually quiet, isn't it? When you're doing a heel strike. If you remember, if you imagine somebody wearing heels, the walking would be like that, isn't it? But then here we go. That would be the sound of that, because the entire leg or the entire foot is slapping on the. A next gait pattern is called scissoring gait or scissors gait. And this is where the legs cross over each other with each step. Typically observed for with people who has either cerebral palsy or spasticity. The legs are scissoring, the adductors are very strong. Okay. The other type of gait, abnormal gait pattern, would be a hemiplegic gait. And hemi from the half, plegia would be a half of the side is paralysis. So the leg swings outward in a circular motion. The reason why it's called hemiplegic is because you would typically observe this from somebody who's had a stroke or possibly a brain injury as well. It's a neurological problem. And then the other one, which I have not used for quite some time, it's called equinus gait. Equinus would be a Latin for horse. And in here, this is where the person is walking on their toes because of the heel elevation. And again, typical for those people who has cerebral palsy or for those people who has shortened Achilles tendon. So you would have Achilles tendon contracture on that one. All right. There we go. We've spoken about different types of the gait. Right? Try picturing these yourselves. Just to remind you again, it's the antalgic gait. You have ataxic gait, Parkinsonian gait, Trendelenburg gait, steppage gait, scissoring gait, hemiplegic gait, and equinus gait. How do we assess gait? How do you analyze walking? There are a few ways. The best way really is through an observational gait analysis. Ooh, it's big. Just watch where the person is walking. Observational gait analysis. You can have gait analysis, observational gait analysis. Again, these are all best-selling initiatives. But that's what you do. And what would a clinician do on situations like this? A clinician would observe a person's walking pattern in varying planes. And what are the different planes? The sagittal view, which would technically be the side view. So when you're observing a person on a sagittal view, you are looking at the person's step length, you are looking at the joint angles, and then you're looking for symmetry as well. The other view is the frontal view or the front and back view. And what you're doing here is you are looking for any hip drops. So you're observing the hip, you're observing the foot placement, and you're looking for any swings on the side, which balance issues as well. When you are doing gaits, so some of the parameters, some of the descriptors that you can describe would be a person's step length. And step length would be the distance between heel strike and the opposite feet. You can have a stride length. Stride length would mean the distance of one complete gait cycle, meaning a heel strike to another heel strike of another foot. Yeah, so that's a stride length. So one step at a time, that is a stride length. Cadence, which would be the number of steps per minute a person can do. You can describe speed, which is velocity, which is the distance that a person can cover over the unit of time, either per minute, how many steps per second, per hour. The base of support, which is the distance between the feet while walking. Normally, it should just be shoulder width. It should be normal. But then a wide base is somewhere that's about more or about longer, wider than the shoulder width, really. And then the arm swing as well. These are parameters. So when you're describing a person's gait and you've observed something that is particularly difficult or different, and you want to document it, you can describe it in terms of the step length, their stride length, their cadence, the speed of walking, their base of support, and their arms swing. Cool. All right. You guys with me so far? Good. What would be the clinical relevance of a gait analysis then? Why is this important? It is important because when you're doing an analysis, it detects the signs of any musculoskeletal problems, or it can identify neurological problem. And when you do know about what's happening or where the problem is, it can help you do the planning. For example, if somebody is walking with a stroke or any injury, you know where the weakness is, then you can plan your rehabilitation. And then if there are some problems and you can restore these things, then you can improve the efficiency. You can design, you can think of using orthotics, you can use prosthesis or prosthetics or some form of other therapy. As an occupational therapist, so the question is, what do we do? Why is it relevant to us? For an occupational therapist, it'd be important because you are using these terminologies when you're doing some functional mobility retraining. That's one. It helps a person regain the ability to walk. So when you're doing functional mobility retraining, you just don't do the walking. You analyze the walking as well. So it becomes a part of our concern. And when you have to prescribe a mobility aid, for example, like a cane or a crutch or a walker, then we can do an assistive device training. Now, in the United States, in other parts of the world, use of walking aids are prescribed by occupational therapists because these are assistive devices. Yeah, while physiotherapists are mostly restorative, we can work on things through adaptive aids. It's still functional mobility retraining. At the end of the day, a person needs to do it safely. Yes, we can. It's part of the ADLs. And then if you want to do some postural control or falls prevention training, you can work on having and doing some balance and strength activities as well. Okay. So the next step is, how do we want to improve the gait, improving the gait, and some of the rehabilitation strategies that are being used. So if there's a physiotherapist, yes, strength training is happening. There has to be a focus on the hip, the knee, the ankle muscles, real specific muscles and specific muscular training. And then physios can do balance exercises like stability and weight shifting control. Physios can do flexibility and stretching as well, so that people can prevent muscle stiffness and contractures as well. Like I said, from the perspective of adaptive aids, then we can help out on functional mobility retraining using adaptive methods, using a modify approach, using canes, walkers, and AFO, ankle foot orthosis. So, in summary, guys, what do we know? When we're talking about gait, there are two phases. That's good to remember. Know that 60% is more on the standing or the stance phase, 40% on the swing phase. A normal gait does involve a smooth transition and there is balanced movement. There will be abnormal gait patterns if there is a problem, either musculoskeletal or structural problems or a neurological problem. When you do gait assessment, it will help on diagnosing the movement problems. Then when it comes to therapy approach, you can use adaptive aids as well. There you go, guys. Thank you so much for listening. I hope you enjoyed this very short talk and conversation involving gait. If you enjoyed it, talk to your friends about it over a cup of tea while you're having your break. Learn together and grow together. If you like it, you can subscribe to Spotify, Apple Podcast, or wherever. Search OT Conversations. If that's difficult to do, OT Conversations, then how? It's HAO, okay? All right. Okay, just remember, guys, anything you do matters and has an outcome. Until next time.